Hi everyone, I'm Alberto Lorenzatti, I'm cardiologist, I'm based in Cordoba, Argentina, and for me it's a tremendous pleasure to be part of this video series from the IAS. The general title is Taming the Flames, Assessment and Management of Atherosclerosis Risks. My topic today is going to be how can we measure inflammation in clinical practice. Let me go. These are my disclosure. Here you can see a classical and seminal review from Russell Rold. He wrote in 1999, and the title was Atherosclerosis is an inflammatory disease. Since that, a lot of information is showing to us that convincing evidence has shown that atherosclerosis is an atherosclerosis in part, an inflammatory disease, an immune, an innate system is involved in the development and progression of atherosclerosis. I would like to mention also other pioneers like Professor Peter Levy and Professor Paul Ridker. They gather a lot of information, a very good evidence in terms of the consolidation of the concept. The inflammasome NLRP3 is a key mediator that reacts to some stimulus to releasing inflammatory cytokines like IL-1 beta, IL-6, and finally C-reactive protein. But the good thing that, of course, many of you know, is that we have now evidence. The intervention in this pathway is showing best results with canakinumab in the CANTOS study, with colchicine in the LOCO, DOE, and COLCOT studies, and we are working and waiting for the results of SUS trial with siltevekimab. So, C-reactive protein is a very well validated inflammatory marker, synthesized by hepatocyte in response to pro-inflammatory cytokines like IL-6. Is a typical acute phase reactant whose plasma concentration could rapidly increase from 10 to 1,000-fold within hours as a response to injury or infection or inflammation. But high sensitivity CRP assay allows the detection of low grade of inflammation and is particularly useful for cardiovascular risk assessment and independently predicts future MACE. Elevated high sensitivity C-reactive protein is associated with systemic inflammation and considered a marker for assessing the risk and developing of coronary artery disease. Additionally, high sensitivity C-reactive protein and other pro-inflammatory mediators like IL-6, TNF-alpha are linked as well to the severity of coronary artery disease and the possibility of future events. The measurement of C-reactive protein is increasingly adopted for vascular risk assessment. The ACC, for example, the prestigious society ACC, are emphasize the universal screening that represent a major clinical opportunity. Other biomarkers, we will focus mainly on C-reactive protein, but I would like to say that IL-6, fibrinogen, serum amyloid A, and also hematological ratios for example, neutrophil to lymphocyte ratio, have predictive values as well, but are not routinely recommended due to the standardization is limited. There is also a limitation with the availability, and there is no incremental value over high sensitivity C-reactive protein. So let's move to the background. Here you can see a classical meta-analysis from 54 prospective studies, 130,000 patients. You can see the relationship between high sensitivity concentration and the risk of coronary heart disease was almost linear, and high sensitivity CRP was almost equal in terms or equivalent in terms of the prediction of future cardiovascular event like systolic blood pressure, total cholesterol, etc. But here you have a more recent example, a very good example. Paul Ritker gathers some data from the prominent, reduced, and strength studied more than 31,000 patients, and you can see in terms of the prediction of MACE, cardiovascular mortality, and total mortality, the basal C-reactive protein level was was a powerful determinant of risk, even when you compare with LDL, the bars in light blue, the prediction of LDL in this patient treated with a statin was almost neutral, but you can see the comparison of the quartiles of C-reactive protein. The bottom to the highest was really impressive in terms of the possibility of future event of MACE, cardiovascular mortality, or even total mortality. Here you have a very recent example from the Women Health study, near 12,000 patients here, comparing the patient with basal more than 3 milligrams per liter of value of C-reactive protein, the incremental risk for coronary heart disease, stroke, or CVD at 30 years was 77% of increase for coronary heart disease, 40% increase for stroke, and 50% increase lifetime, for cardiovascular disease. The author conclude that inflammation represent an important, measurable, and modifiable source of risk for traditional that traditional algorithm fail to capture. But let me point out that in this case, all patients have had no standard modifiable risk factors, and this was the very important thing in this study. What about the levels of LDL and C-reactive protein? You can see this, probably you has been several times this image. Evolocumab do not modify the level of C-reactive protein, but in the Fourier study, there were more or less 30% of patients having C-reactive protein more than 3 milligrams per liter, and even if you can see in the bars in the left of the bars image, patient with less than 20 on treatment milligrams per deciliter of level of LDL, but more than 3 milligrams per liter of CRP level, they showed an incremental risk for events. And finally, also a recent example again from the Women Health study, also comparing basal levels of LDL, high sensitivity C-reactive protein, and LP little a, of course, comparing the bottom quintile against the top quintiles, the hazard risk for high sensitivity C-reactive protein was 1.7 in comparison of 1.36 and 1.33 for LDL and LP little a respectively. So, and finally, if you gather the objective of a reduced LDL, like in these studies, the prove-it study and the improve-it study, patients who achieve both target, LDL less than 70 milligrams per deciliter and C-reactive protein less than 2 milligrams per liter, they show the better result, the bottom curve in the screen. So what about guidelines? This is the 2018 ACC/AHA guideline for the management of blood cholesterol. For this guideline, elevated high sensitivity C-reactive protein more than 2 milligrams per liter is a risk enhancing factor, similarly to elevated LP little a or elevated ApoB. But this is an important consideration because here I'm showing to you the suggestion of the recommendation of the American College of Cardiology 2025 scientific statement on C-reactive protein. They recommend the universal high sensitivity C-reactive protein screening for both primary and secondary prevention. On the other hand, the European Society of Cardiology measurement, they suggest the measurement of CRP only in selected individuals at intermediate risk, but they do not recommend for the routine screening. The consensus of the American College of Cardiology incorporate CRP in the risk stratification also for allow us the management decision. By the contrary, the European guidelines also as an additional to the traditional risk factor and also in ambiguous cases, but they not suggest to include in the standard risk algorithm. The rationale of the recommendation of the American College of Cardiology is that the high sensitivity C-reactive protein provides independent, additive prognostic information comparable to LDL and blood pressure. In summary, inflammatory markers, C-reactive protein, should be measured to estimate and guide the treatment. My answer is yes, because C-reactive protein is well-validated marker for chronic inflammation. Also, I would like to mention that C-reactive protein has a long half-life, stable circulating levels, and minimal circadian variation. Also is widely available and also affordable determination. The persistent elevation of C-reactive protein may indicate residual inflammatory risk that contribute to MACE independently of LDL level. Also, CRP has a prognostic value for mortality and recurrence of cardiovascular events in primary and also in secondary prevention. And finally, in according to the example that I mentioned from the improve-it, prove-it, inflammation and hyperlipidemia are synergistic, and both approaches should be used as a strategy to risk reduction. So I would like to finalize showing this cartoon. I think the C-reactive protein in clinical practice is still underused, is more or less like the case of the elephant in the room. I would like to emphasize the necessity to improve the management of our patient measuring high sensitivity C-reactive protein in clinical practice. Thanks for your attention.
Thank you very much for your presentation. It was a really good summary of how CRP can be very valuable for us in our practice. I'd like to introduce myself. My name is Viviane Rocha. I'm a cardiologist from São Paulo University, and I'm supposed to discuss with Alberto for a few minutes about inflammation, about his presentation. And Alberto, I think it's a very exciting time for those who really believe inflammation should be used in clinical practice, because we've experienced for years studies that showed how inflammation was very important in the plaque formation and also plaque complications. But it took a very long time for inflammation to be used in the clinical practice. So I think the use of CRP and I think more recently therapies that can attenuate inflammation, this is very exciting for cardiologists. So I have a question for you. Based on the differences in the guidelines, so AHA is really not, the statement is now suggesting the use in primary and secondary prevention. The European guidelines are still getting used to it. So what do you do in your practice? Do you measure in all patients in the first consultation, in all the consultations to follow CRP? What do you do and what do you suggest?
Thank you, Viviana. It's an excellent and practical question. I use high sensitivity CRP often in the clinical practice. Especially, I incorporated the high sensitivity CRP in the expanded or advanced lipid panel. So if I prescribe a routine lipid panel, cholesterol, total cholesterol, LDL, HDL, and triglyceride, generally I do not introduce the determination of CRP. But when I ask for LP(a), for ApoB, etc., I usually include C-reactive protein, and also especially in cardiometabolic patients. You know, in your talk, you are going to address the cardiorenal metabolic syndrome, but this kind of patient are particularly patients who have inflammation in general, and is very useful tool in this population. I use very, very often in patients with obesity, diabetes, pre-diabetes, etc. The thing is that, look, this is a case that tons, literally tons of evidence we have, and still doctors are reluctant to indicate the determination of CRP in clinical practice. We can manage some tips, maybe two determinations, maybe if the patient has a level more than 10 milligrams per liter, there is no absence of cardiovascular risk, but perhaps could be a case of other acute inflammatory illness or rheumatology illness, but I think we definitely have to incorporate the measurement of CRP in the routine clinical practice. What about you?
Yes, Alberto. I've been using a lot CRP. I think because CRP is really influenced by several factors, I think cardiologists were a little bit concerned to use it and oh, if it's influenced by everything, why should I use it? But exactly because you can change it. You can change it, right? You can change it if you stop smoking, if you lose weight, if you treat well lipids and hypertension. So I think it's a guide that you're doing the right thing, right? If you're getting a lower CRP, I think it means that you're in the right direction. So it's totally different from Lp(a), for example, which is mostly genetics. So it's gonna give you a risk, but for now we can change it. But CRP, we can change it. So let's measure and try to reduce it through lifestyle and sometimes through medications when it's indicated. So I do measure it.
Let me
But
add
okay, Alberto,
something. Uh,
I'm sorry.
you know nowadays LP little a is in the is in fashion. Everyone is asking for LP little a, but we need evidence. We know it's a risk marker. We know probably it's a causal factor, but in the case of C-reactive protein, it's not a causal factor, but it's a very good marker. If we have evidence that reducing inflammation, we will reduce events. Also, we have tools in 2023. FDA approved low dose of colchicine for this kind of patient that are showing levels of inflammation in clinical practice, mainly if you have treated them with statins, with all the evidence-based medicine and secondary prevention, and still have the patient still has inflammation. I think is we do not have to lose this kind of opportunity in clinical
I
practice.
agree. I agree with you. I think we close the cycle, right? We have all levels of evidence showing that inflammation measured by CRP is useful. So I think cardiologists can feel a little bit safer, right, measuring it and doing all the initiatives to trying to reduce it. So I think it's exciting. I think the phase for inflammation.